Shui, much of what we do is based on our own experience. And of course, we have, in many cases, guidelines that we can sort of fall back on to help us decide what's the best form of therapy. I don't know about you personally, but in how I sometimes implement guidelines, there could be a bit of a difference between what the guidelines say and what I do. I'd like to think that as much as possible, I'm trying to stick to guidelines in terms of how I treat stroke. I guess, I'd like to know about how you feel in terms of implementation of guidelines. And what do you think the gaps might be in terms of how those guidelines are actually being implemented in your country and by your colleagues?
Well, yes, I think in my practice, I will learn something from guidelines, but I will give treatment based on both guidelines and my own understanding of the stroke pathophysiology. For general physicians, however, they should learn much from, and they should go with the guidelines, I think. In Chinese, in China, so, sometimes some physicians give more aggressive treatment to patients with normal LDL-C level and with plaque finding, imagined finding of plaque by duplex Doppler or by other imaging methods. So that's wrong. So we only give symptomatic patients to patients with large artery atherosclerotic stroke patients with aggressive LDL-C treatments, not the patients with only a plaque on of Doppler, the duplex Doppler. So without LDL-C, high LDL-C level. So we should give more education to general physicians and non-stroke neurologists.
I think I couldn't agree more. I think that by and large, stroke neurologists are going to stick to the sort of guidelines, are going to sort of try and achieve those treatment targets, whether it's for blood pressure or glucose or for cholesterol levels. And as you rightly pointed out, the further away we move from people who are used to dealing with stroke in terms of secondary prevention, whether you're then going to general physicians or whether you're going to family physicians, general practitioners, there's perhaps that they're not, I feel perhaps as comfortable as being aggressive in treatment. And I wonder what in your population, amongst your colleagues, why do you think it might be that some of your general physician colleagues or family physician colleagues, why do you think they might be a little less aggressive in wanting to treat total cholesterol and LDL cholesterol to target?
I think they don't have much knowledge of the LDL-C treatments. They are more concerned about the side effects if they give the aggressive treatment, lipid lower treatment. However, they do know some knowledge about stroke prevention. So they will give some treatment, LDL-C lower treatment to the patients with a plaque. That's their concept. So we need to teach more stroke etiology and to give more education of stroke, a basic concept of stroke to the general physicians. So let them understand stroke. So that will helpful for them to to truly know what the guideline means.
So I guess it's a question of not just knowing the guidelines, but it's a question of understanding what it is the disease state is about.
Yeah.
So an understanding of all of the risk factors that come into play, the kinds of strokes that we see, and going further than, is this ischemic stroke or hemorrhagic stroke? If it is ischemic stroke, what sort of stroke is it? Large vessel, small vessel, cardioembolic,
Yeah.
as you've pointed out. And in that sort of setting, encouraging our colleagues to sort of think that, okay, if this is the sort of stroke mechanism, this is the sort of target that I should be hoping to achieve for total cholesterol and LDL, and knowing what they can use to achieve those targets.
Yeah.
I don't know what it's like in China, but in Australia, statins unfortunately have a slightly bad reputation for causing cognitive impairment, memory issues. There's a perception amongst our population that these are potential side effects of statins. I don't know whether you've seen something similar in your population.
So it's very interesting. Some cardiologists are concerned about the memory problem of lipid lower therapy. But for neurologists, they seems don't think that lipid lower therapy, statin therapy, will give have a side effect on memory issues. So it's very interesting. So I think we should. So just now I have said that if the doctor understands the pathophysiology of lipid lower therapies, they will think they are safe and they can give the proper treatment. They don't know, so I think they will think it may be dangerous, and they will stop them from proper lipid lower therapies.
Shui, when we think about cholesterol, when we think about the various aspects of total cholesterol, triglycerides, LDL, HDL, we are reminded that there is a physiological role for cholesterol and all of these other forms within the body. Have you come across colleagues who are concerned that lowering LDL too much might actually pose a danger to the patient? And what are your thoughts on this?
Well, in China, there is some concerns about liver function. So when patients were given the statin therapies, the doctors are always concerned about liver function because there is a lot of alcohol consumption in China. So especially in male patients, if they eat a lot of alcohol, so they will, when lipid lower therapies are given, the doctors will be concerned about the liver functions. And also in general media, the general media have give some impression to the general people that lipid lower therapy, especially statin therapy, will have will give an injury of liver function. That's the Chinese condition, the situations now.
But what are your thoughts about specifically in terms of lowering LDL? Do you think that there are any dangers associated with lowering LDL? Is there such a thing as too low?
Yes, in my experience, actually, I give treatment to the stroke patients every day. So for so many years, I don't have any patients with severe side effect after I gave the lipid lower therapies. Some patients have some higher, have some liver function injury, but it's very uncommon. So actually, it's safe. I think the same with the results of so many trials. So it can, in my experience, we also confirm that the safety of the lipid therapies.
I think there seems to be a concern, especially whether very low LDL levels might affect cognition. And I think, as you said, you were speaking about the trials. So we have evidence from Prosper, we have evidence from Ebbinghaus that this doesn't seem to be the case, that low levels of LDL, even up to 0.6, don't seem to have any sort of neurocognitive effect. And from the sub-analysis of the Fourier trial as well, we have similar evidence. So I think for now, it's safe to say that lower LDL levels do not pose a sort of a danger to the patient. That if we're specifically concerned about, neurocognitive side effects, there's nothing to be worried about. And that this is, I think, going to be a growing field of research, that as the years go on, we're going to get more and more information.
Yeah.
That hopefully, as we were discussing, make it sort of easier for our colleagues to say that this is an approach that we can take in terms of lowering LDL.